read this with you. 35-year-old, okay, 10-year history of daily alcohol, okay. Progressive exertional dyspnea, orthopnea, lower limb edema, so definitely heart is undergoing some failure, okay. Elevated jugular venous pressure, displaced and diffuse apical impulse, and a third heart sound, chest X-ray, marked cardiomegaly and pulmonary vascular congestion. Echo reveals enlargement of all cardiac chambers, a thin left ventricular wall, reduced movement of the interventricular septum. Question is, which of the following additional findings? Now, this is becoming a little difficult here. Additional findings most likely observed in this patient. Okay, so what has happened here again is history of alcohol is given to us. So fairly young, I mean, 35-year-old, 10-year history of alcohol. So alcohol is another thing that can lead to a dilated cardiomyopathy. You knew that? Okay. So if you have any questions, you please put them in the chat. Okay. So this is alcohol now causing cardiomyopathy. Okay, so again, what type of cardiomyopathy? Again, dilated. So you see today why dilated cardiomyopathy is the very top most common type of cardiomyopathy out of the total four that we learn, isn't it? Okay, so what would be the correct answer here? Okay, so this is dilated cardiomyopathy. Okay, so what describes our dilated cardiomyopathies? Increase left ventricular and diastolic volume with reduced ejection fraction. Okay, a very lengthy option, but this is one of your UWorld type of questions, which is definitely love to ask you in your USMLE step 1. So this is increased left ventricular, again, and diastolic volume with reduced ejection fraction. What has happened here? The heart muscle, the heart chambers are dilated. Heart has expanded, and there is volume overload that has happened in the heart. So there is too much of volume of blood that has gone into the heart. So the heart is going to have a very difficult time ejecting all of that blood out in one cycle, isn't it? When it contracts, it cannot push everything out. So that is why reduced ejection fraction. Okay, I love to show you this picture. So this is the three types of cardiomyopathy. We have a fourth one too. We can talk about that, but three top important ones. Okay, so this is your dilated in the center here. So this is a big heart with too much of blood in it and having a very difficult time, pushing all that blood out. So ejection fraction is the amount of blood coming out of the heart in every heart cardiac cycle. So that is going to be reduced. So cardiac output reduced. The fraction of blood that was in the heart, okay, all of that cannot be pushed out, or a percentage, it's usually close to 65% that is given out by the heart. It does not happen because it is too much. There is volume overload that has happened in the heart. Okay, then we have hypertrophic is thick cardiac walls. Most likely it's the thick ventricular walls or interventricular septum. We can talk about that too. And then the third one is restrictive. Okay, so restrictive can happen because of, for example, amyloidosis. Okay, so amyloidosis question with restrictive cardiomyopathy has been again repeatedly asked in your exams. So